Good morning, Dr. Phil here. Today we will be discussing on cleft lip and cleft palate. Introduction. Epidemiology. CLP is one of the most common congenital deformities. Incidence of cleft lip or cleft palate is 1 per 500 to 700 births worldwide. It affects boys more than girls. Both lip and palate are involved together in 50% of cases. There is increased incidence of congenital abnormalities, and associated syndromes often involve a difficult airway. Facial disfigurement causes feeding, speech and dental development problems and psychosocial consequences. Surgery aims to restore form and function, and modern techniques can leave many defects undetectable. CLP may be unilateral or bilateral, complete or incomplete. Causes is multifactorial, with environmental and genetic causes contributing. CLP is familial. Impaired mandible development can prevent the tongue descending, which obstructs fusion of palatal shelves. Teratogens implicated in CLP includes alcohol, smoking, anticonvulsants, salicylates, and cortisone. The risk of CLP increases with increasing paternal and maternal age. Patients with CLP likely need multiple procedures and anesthesia throughout their lives. Cleft lip is usually repaired at 3 months old. Cleft palate is usually repaired at 6 to 9 months old. At 4 to 6 years old, 20% will require Pharyngoplasty for velopharyngeal dysfunction. Adolescents may require orthodontics, alveolar bone grafting, and orthodontic surgery. Malformation syndromes associated with cleft lip and/or cleft palate and features with possible anaesthetic implications. This includes Down syndrome. Kindly refer to the video on Down syndrome for further information. Smith-Lemli-Opitz syndrome. Features includes micrognathia, dysmorphic facial features, vomiting, GE reflux, chronic lung disease, congenital heart disease such as TOF and VSD, and renal abnormalities. Arscock syndrome. Features includes vertebral laxity and odontoid abnormalities. Avoid excessive neck manipulation. Coffin-Siris syndrome. Features includes facial dysmorphism, microcephaly, short neck, macroglossia, cleft palate, possible difficult intubation, respiratory tract infections, core-anal atresia, joint hypermobility, renal abnormalities, and congenital heart disease such as PDA, ASD, VSD, and TOF. Van der Wood syndrome. Features includes dental abnormalities, oral synechiae, limiting mouth opening, oral syngnathia, may necessitate nasal intubation. Waardenburg syndrome. Features includes hearing loss and scoliosis. Ectodermal dysplasia syndromes. Features includes dental abnormalities, choanal atresia, fragile skin, renal abnormalities such as dysplasia, hydronephrosis, and vesico-urethral reflux, hearing loss, hypoplasia of sweat glands, abnormal temperature regulation, and lacrimal duct hypoplasia. Distal arthrogyropsis type 2. Features includes micrognathia, microstomia, neck shortening, cephalate positioning of the larynx, pharyngeal airway obstruction from pharyngeal muscle myopathy, recurrent aspiration pneumonia leading to chronic lung disease. Other features include scoliosis, extremity contractures, and deformities of the hands and feet. Fryns syndrome. Features includes congenital diaphragmatic hernia, lung hypoplasia, microretrognathia, delayed gastric emptying, congenital heart disease such as VSD and aortic arch abnormalities, hydrocephalus and renal disease. Popliteal pterygium syndrome. Features includes intraoral webbing, which limits mouth opening, posterior displacement of the tongue, careful positioning of lower extremities as the sciatic and popliteal artery are contained within popliteal webs. 22q deletion syndromes, such as DiGeorge syndrome. Features includes micrognathia, retrognathia, choanal atresia, congenital heart disease such as TOF, right aortic arch, vascular ring, displacement of carotid arteries, aberrant subclavian arteries, T-cell defects, hypocalcemia, and hypothyroidism. Wolff-Hirschhorn syndrome. Features includes micrognathia, recurrent aspiration, congenital heart disease, scoliosis and congenital hip dislocation. Basal cell nevo syndrome. Features includes dental abnormalities, scoliosis, cervical vertebral abnormalities, and hydrocephalus. Kalman syndrome. Features includes hyperthyroidism, hearing loss, high arch palate, choanal atresia, and hypogonadism. Neil patella syndrome. Features includes weakened teeth, limited joint mobility, tendency for joint dislocations, glaucoma, renal insufficiency, and proteinuria. Multiple malformation syndromes associated with cleft palate and features with possible anaesthetic implications. Down syndrome. Kindly refer to the video on Down syndrome for further details. Prader-Willi syndrome. Features includes morbid obesity, risk of OSA, rumination, insatiable hunger, and hypoglycemia at approximately 1 year of age. Non-insulin dependent diabetes mellitus as adults. Campomelic dysplasia. Features includes micrognathia, short neck. The patient may require smaller than expected endotracheal tube. Cervical vertebral anomalies, unstable cervical spine, possible respiratory insufficiency, risk of perioperative apnea, tracheobronchomalacia, airway obstruction, possible hydronephrosis and renal dysfunction. Sickler syndrome. Features includes micrognathia, joint laxity and arthritis, and glaucoma. Avoid anticholinergic medications. Holoprosencephaly sequence. Features includes oral or midline facial defects, such as nasal defects, absence of philtrium or labial frenulum, cleft lip and cleft palate. All these lead to possible difficult mask ventilation and intubation, seizures, perioperative temperature instability, and hypernatremia. Cornelia de Lange syndrome. Features includes micrognathia, high arch palate, short neck, choanal atresia, GE reflux, pulmonary aspiration, risk of apnea in infancy, congenital heart disease such as VSD, valvular pulmonary stenosis, flexion contractures, severe mental and motor delay, autism, self-destructive behavior, and micromelia. Micromelia may cause difficult vascular access. Next is spondyloepiphyseal dysplasia congenita. Features includes short neck, limited flexion, cervical spine instability, restrictive lung disease, limited joint mobility, ensure careful positioning, and small stature. The patient may require smaller than expected endotracheal tube. Treacher-Collins syndrome. Features includes severe mandibular hypoplasia, small mouth, and narrow airway, leading to difficult intubation. The patient may have OSA. DiGeorge syndrome has been discussed previously. Diastrophic dysplasia. Features includes laryngotracheobronchomalacia or laryngotracheal stenosis. The patient may have airway obstruction and may require smaller endotracheal tube. Micrognathia may lead to difficult intubation. The patient may have restrictive lung disease, risk of subluxation at C2 and C3 with spinal cord compression. Avoid hyperextension of the neck. Limited joint mobility. Ensure careful positioning. Orofacial digital syndrome type 1. Features include small mandible, dental abnormalities, and choanal atresia. Otopalatal digital syndrome type 1. Features include small mouth, micrognathia, and dental abnormalities. Nager syndrome. Features include small mouth, micrognathia, hypoplasia of the larynx, choanal atresia, and limb abnormalities. Smith-Lemni-Opitz syndrome. Features includes dysmorphic facial features and micrognathia, increased risk of aspiration, chronic lung disease, TOF, VSD, and behavioral problems. Apert syndrome. Features includes small nasopharynx, choanal atresia or stenosis, tracheal stenosis, and abnormal cartilage, leading to difficult intubation, cervical anomalies including fusion, OSA, proptosis, necessitating eye protection, possibly elevated ICP, congenital heart disease such as pulmonary stenosis, overriding aorta and VSD, and genitourinary anomalies such as polycystic kidneys, hydronephrosis, bicornuate uterus, vaginal atresia, and cryptorchidism. Marfan syndrome. Features includes CVS, risk of aortic dissection, avoid hypertension, aortic or pulmonary artery dilation, aortic insufficiency, mitral prolapse, medial necrosis of coronary arteries. Respi system, pulmonary blebs with risk of pneumothorax, OSA from pharyngeal laxity, joint laxity, ensure careful positioning, dural ectasia, leading to inadequate spread of spinal anesthesia, glaucoma, avoid anticholinergics. Turner syndrome features includes short web neck, short trachea, coarctation of aorta, bicuspid aortic valve, risk of aortic dissection, hypertension, and hypothyroidism. Cleidocranial dysostosis features includes dental anomalies, narrow thoracic cage, reducing perioperative respi reserve, joint laxity, fragile bones, ensure careful positioning, vertebral anomalies, leading to difficult neuraxial techniques, hypoplasia or aplasia of the clavicles. This may alter subclavian artery, vein, or plexus landmarks. Anesthetic implications of CLP. General considerations for pre-op assessment. Identify syndromes associated with CLP prior to delivering anesthesia. Many of these are associated with difficult intubation. Several organ systems may need to be investigated. Airway assessment and management. Identify features of difficult airway. Frequency of difficult intubation in children with CLP varies from 4 to 8%. Consider antimuscarinics preoperatively if difficult airway is suspected. URTI is common. If a patient has URTI on the day of the procedure, risk and benefits of the procedure needs to be discussed with the surgeon due to increased risk of perioperative respi complications such as bronchospasm and laryngospasm. These risks take on a particular significance in children with existing congenital heart disease or difficult airway. Chronic rhinorrhea is common in children with CLP due to food reflux into nasal passages, and they may present with recurrent URTI. Risk of post-op respi complications increases with the severity of the defect. Even if clinically well, pre-op antibiotics for children with low-grade infection reduces the incidence of post-op respi complications. Surgical repair reduces rhinorrhea and URTI, so risk of anesthesia and PRC should be individualized. Chronic airway obstruction may be indicated by snoring and apnea during feeds or protracted feeding time. Older children and adults may have chronic hypoxia, right ventricular hypertrophy, and cold pulmonale. Patients with OSA are more sensitive to sedative drugs. They have increased risk of airway obstruction at induction and post-op. If cardiac involvement is suspected, ECG, echo, and other performance tests should be considered, and higher level post-op monitoring is advised. Pre-medication. Sedatives may precipitate airway obstruction and should be avoided. Anticholinergics, if not contraindicated, is helpful in reducing secretions which may facilitate intubation and also counter the hypersecretory effects of ketamine when used. Nutrition and hydration. Feeding difficulties are common. Surgery should be deferred in the malnourished and dehydrated children. Nutritional or physiological anemia may be present. Anesthetic considerations during cleft lip repair. Pre-op assessment, as in general mentioned previously. Benefits of cleft lip repair includes improved physical appearance, increased weight gain from facilitating feeding, and increased capacity for correction of nasal deformities. Group and screen is usually sufficient for infants with hematocrit less than 30%. If the degree of anemia is more severe than expected, further investigations may imply an underlying cause. Cleft lip repair in adults and older children can be performed with LA infiltration and conscious sedation. All other patients require general anesthesia. In resource-limited settings, routine cleft lip repair has been described using only ketamine, atropine, and LA infiltration. Intraoperative considerations. Induction. In general, a technique that maintains spontaneous ventilation should be chosen. Inhalational induction is suitable for most, for example using sevoflurane in oxygen. IV induction is an option if IV access is present. Ketamine is advantageous as it maintains spontaneous ventilation, unlike propofol or thiopental. IV access, if not already established, should be obtained as soon as the child is asleep and face mask ventilation confirmed before the use of any neuromuscular blockers. Difficult airway. Anticipate difficult mask ventilation and intubation, especially in patients with craniofacial abnormalities and micro or retrognathia. CPAP and oropharyngeal airway can be utilized to assist ventilation when necessary. Other options in difficult mask ventilation includes LMA and positioning the patient lateral or semi-prone. CLP repair is not a life-saving surgery. If the airway cannot be managed safely, surgery should be deferred until the patient is older, when maturation often makes airway management easier. Endotracheal intubation may be performed under deep inhalational anesthesia or using muscle relaxants. Risk factors for difficult laryngoscopy includes congenital anomalies, especially micrognathia, age less than 6 months old, combined cleft lip and cleft palate, left cleft lip and alveolus deformities, combined bilateral cleft lip and palate, and previous CLP repair. Maintenance. A head ring and roll under the patient's shoulders, extend the neck and tip the head down. Throat packs are used to absorb blood and secretions. Options for inhalational agents include sevoflurane, desflurane, or in resource-limited settings, halothane with draw-over systems. IV agent options includes Tiva or ketamine boluses. Regarding ventilation, spontaneous ventilation techniques are safer if there is a disconnection or inadvertent extubation, but are not suitable in infants or small children. Controlled ventilation with muscle relaxants reduces anesthetic requirements, promoting a more rapid wake-up and recovery of airway reflexes, as well as allowing for lower PaCO2, which may reduce blood loss. Options for analgesia includes LA with adrenaline. Adrenaline reduces surgical bleeding and improves the surgical field. Infraorbital nerve block is an effective block for this type of surgery. Paracetamol is used to augment analgesia and reduce opioid requirements. Postoperatively, ensure smooth emergence to limit the damage to delicately sutured repairs. Presidex can be used. Regarding analgesia, infraorbital nerve block assists in smooth emergence. Little if any opioid is needed for cleft lip repair. Pain control is usually adequate with paracetamol. Next, we move on to anesthetic considerations for cleft palate repair and pharyngoplasty. Introduction to cleft palate repair. The purpose is to obtain velopharyngeal competence and normal speech, typically performed at 9 to 12 months of age. It involves hard palate repair, repair of nasal lining flaps, velar repair, and mobilization of soft palate tissue to the midline. Raw areas are expected to heal by granulation, with serosanguinous drainage during the post-op period. Pharyngoplasty is performed to reduce velopharyngeal incompetence and improve speech in patients who have undergone cleft palate repair. It can be done by a pharyngeal flap, sphincter pharyngoplasty, and palatal lengthening. Velopharyngeal ports function as nasal airways and connect posterior nasal cavity and pharynx. Pharyngoplasties alter the anatomy of velopharyngeal port and posterior pharynx. These patients carry lifetime risk of overcorrection, hyponasality, and OSA. Preop assessment is as in general. Review previous anesthetic records for the details of previous airway management. Intraoperative considerations. Induction. Most can be induced with inhalational induction. Those with craniofacial abnormalities and retrognathia should be kept spontaneously breathing until airway is secured. These patients often have features of difficult airway. Techniques that facilitate intubation includes inhalational induction and CPAP, and intubate the child when the child is in deep anesthesia, when the child is breathing spontaneously or following muscle relaxant. A video laryngoscope may be necessary. Anterior laryngeal pressure and use of gum elastic bougie may be helpful. The laryngoscope blade rarely lodges in the cleft. If this is a problem, a roll of gauze can fill the gap. Intubation through an LMA with the aid of a fiber optic scope has been described. A guide wire may be threaded down the suction port of an adult endoscope. The LMA and endoscope can be then removed, and the wire used to railroad a ETT. The pediatric endoscope may also be used to introduce a preloaded endotracheal tube directly through the LMA. An LMA may also be used to allow for CRP repair. Use of a straight blade via the paraglossal approach has been described. Insert a laryngoscope with a Miller blade from the left corner of the mouth along the groove between the tonsil and the tongue. The blade is advanced, epiglottis lifted to expose the glottis, taking care to avoid inserting the blade into the cleft. Emergency surgical airway is rarely necessary. Avoid nasal intubation if the patient had pharyngoplasty. Use a throat pack and ensure that the eyes are protected. Choice of ETT includes oral ray tube or reinforced tube. The ray tube is used most commonly for endotracheal intubation for cleft palate surgery. It is placed centrally, which allows the Dingman mouth retractor to be placed in a convenient position. The ray tube may need to be pulled back to prevent endobronchial intubation in small infants. Neck flexion may advance the endotracheal tube, and neck extension may result in inadvertent extubation. The preformed ray tube may become obstructed or kink, especially for the smaller sizes. Reinforced tube is a useful alternative that does not kink. Vigilance is needed to monitor for shared airway problems such as accidental extubation, endobronchial intubation, and tube kinking or occlusion. Dexamethasone is used to prevent post-op airway swelling. Blood loss is typically insignificant in patients without coagulopathy. However, facilities for cross-matching should be available. Existing fluid deficits and intraoperative losses should be replaced with balanced crystalloids. A single shot of IV antibiotic such as augmentin is usual. Options for maintenance includes TIVA or inhalational anesthesia. A balanced anesthetic with inhalational agent, opioid, and muscle relaxant is generally considered safe. Options for analgesia includes LA infiltration, opioids, paracetamol, NSAIDs, nerve blocks, and Presidex. 1% lidocaine with 1 in 200,000 adrenaline provides intraoperative analgesia, reduces blood loss, and improves the surgical field. If halotane is used, avoid exceeding 5 micrograms per kg adrenaline due to risk of arrhythmias. Benefits of opioids includes obtaining the stimulation from ETT movement. It promotes a smoother emergence with less crying, less airway swelling, and bleeding from surgical site. However, opioids should be used judiciously due to the risk of sedation, respiratory depression, and airway obstruction at the end of the case. Paracetamol can be given orally as pre-medication or rectally after induction. Regarding NSAIDs, most pediatric anesthetists prescribe them to infants over 6 months old. However, there is a risk of post-op bleeding, thus some advocate delaying administration until 12 hours post-operatively. Infraorbital nerve block is a useful technique for analgesia. Dexmedetomidine may reduce emergence delirium and facilitate smooth emergence. Extubation. Ensure smooth emergence. Throat packs should be removed at the end of operation. Oropharynx inspected for blood clots and to check hemostasis. Gentle suction of the pharynx. Avoid damage to the repaired site. Antagonize non-depolarizing muscle relaxants if used. The pharyngeal space is dramatically reduced due to surgery. Acute upper airway obstruction post-extubation may be caused by swelling of the tongue due to compression by the mouth retractor, airway edema, blood clots, residual anesthetic effects, laryngospasm, or retained throat pack. Extubation must occur when airway reflexes have returned and the child fully awake. Nasopharyngeal airways are often placed at the end of cleft palate repair or pharyngoplasty in patients at high risk of post-op airway complications. These can usually be removed the following day once swelling has subsided and the child has mastered mouth breathing. Avoid oropharyngeal airways due to risk of disrupting the surgical repair site. A tongue suture may be placed to exert traction and facilitate immediate post-op control of the airway at the recovery. Post-op considerations. The goals includes monitoring and treating airway obstruction, adequate analgesia, treat post-op nausea vomiting, detect and treat respi depression, and avoid suture disruption. Monitor for upper airway obstruction for 48 hours, presence of other congenital anomalies, is associated with increased risk of airway obstruction. Monitoring should include SpO2, apnea alarms. Some centers use arm restraints to prevent suture disruption and removal of airways. A short period of CPAP and turning the child lateral or prone may be helpful. Consider reintubation and mechanical ventilation for those experiencing worsening respiratory distress, as it may take several days for tissue edema to resolve. Options for analgesia includes paracetamol, NSAIDs, opioids, palatal nerve block, and bilateral suprazygomatic maxillary nerve block. Complications described most commonly for pharyngoplasties includes vomiting, pain, airway obstruction, bleeding, apnea, surgical revision due to severe bleeding or airway obstruction. Fewer complications were seen if sevoflurane and propofol was used as the main inhalational or IV anesthetic respectively. Children can be reluctant to feed. IV fluids should be continued until adequate oral intake is established. Regarding subsequent airway management, any subsequent procedures involving nasal intubation should be done with caution to preserve the integrity of the cleft palate and pharyngeal flap repair. Care should be taken prior to inserting an LMA in a patient with history of cleft palate repair due to the risk of disruption of cleft palate repair during LMA placement. These are my references. Thank you.